Welcome back to Epidemiology and Biostatistics. So today's topic is measures of disease and indices of health, and I am Dr. Muhammad Razif bin Shahril. So at the end of this lecture, you should be able to outline the common measures of morbidity and mortality, define and calculate and state the uses, state the factors of prevalence and incidence, state the sources of morbidity and mortality data, and finally, define common health indices and vital statistics in Malaysia. So, as an introduction, measures of disease frequency are used to characterize the disease status and health of the population. So, these measures are an important public health indicator, and it is usually expressed in quantitative terms. There are two usage of measures of disease frequency. The first one is to monitor the trend for improvement, and second one is for countries comparison. So we have two types of measure. The first one is measures of morbidity. The examples are incidence and prevalence. And the second type is measures of mortality. And the examples are case fatality, proportionate mortality, crude death rate, adjusted death rate, and cause-specific death rate. So we mentioned just now there are two types of measures, which is morbidity and mortality. So where do we get this data from? So sources of mortality data are from vital statistic registration, hospital records, notification of diseases, national specific health surveys, and other organizations like police, and so on. And sources of morbidity data are from hospital records admission and discharges, outpatient and primary health care including health clinics, national special health surveys, specialist services such as injury treatment, registers of disease events such as cancer, and also screening program and research. So by now, you should be able to understand that mortality is about death and morbidity is about getting a disease. So this slide shows the basic formula for a measure. So we have measure equals to numerator or x divided by denominator. So rate, ratio, and proportion sound similar, but each of them have a different definition. Ratio is a fraction in which the numerator is not part of the denominator. It is expressed the magnitude of an occurrence or condition in relation to another. Example S is fetal death ratio is equal to fetal death over live birth. When we look at proportion, proportion is a fraction in which the numerator is part of the denominator. Now, let's look at rate. Rate is the numerator included in denominator, and denominator represent the entire population at risk. So rate is an expression of the frequency in which an event occurs in a defined time period in a defined population at risk during the period. Example is cruise death rate. When we look at rate can be divided into three. The first one is crude rates. The second one is specific rates. And the third one is adjusted or sometimes called as standardized rates. Crude rates is applied for entire population without referring to any characteristics. Crude rates can be misleading when we compare index from different population because they do not take into account differences in population characteristics. Specific rates consider differences among subgroups computed by particular characteristics, example, age, race, and sex, or others. So you might have specific rates for male or specific rates for female. Whereas for adjusted or standardized rates, they remove the differences, example, age, sex, and other factors in the population distribution to allow valid comparison across population. So these differences were removed by statistical or formula. Moving on to the first type of measure, which is morbidity measures. So there are two major measures of disease occurrence. The first one is incidence and second one is prevalence. So incidence refers to the occurrence of new cases in a population over a specific period of time. Prevalence refers to the total number of existing, that includes new and old cases, of a condition in a population at a specific point in time. So the definition of incident is number of new cases of a disease that occur during a specific period of time. This is the numerator divided by population at risk developing the disease over that time, which is the denominator. Incidence measures the probability that healthy people will develop a disease during a specified period of time. This slide includes the formula for incidence, and you can see that the numerator and denominator is number of new cases occurring in a population in a given period of time over total number of people in the same population during the same period of time and times 1000 population. This 1000 population will be the unit for the incidence. People who are susceptible to a given disease and can be defined by demographic, geographic, or environmental factors are considered population or person at risk. So example of population or person at risk is in a health event of breast cancer, the population at risk is women aged 18 years and above. For a health event which is occupational injuries, of course, the population at risk would be all working people. And there are a few other examples in these slides, which includes motor vehicle accidents and erectile dysfunction. There are two types measures of incidence defined by similar numerator but different type of denominator. The first one is cumulative incidence, where person at risk as denominator. So person at risk is who are observed throughout a defined time period. For incidence density, person time at risk is the denominator. Person time is equal to the sum of all the disease free during the period of observation of the population at risk. And we can get this by multiplying the average size of the study population by the length of the study period. Person time is used because some people are not observed for the full time period due to the death or other reason and lost to follow up. This slide shows the difference in formula for cumulative incidence and incidence density. So cumulative incidence or CI is equal to new cases during stated period over number of person at risk. Incidence density or ID is equal to new cases during stated period over population time. This slide shows the demonstration on how to calculate person year. So the numbers 1 to 12 on your left is the ID of a subject, whereas at the x-axis of this graph is the year from 1980 to 1994. X is equal to when the disease occurred. As an example, patient number 2 got the disease in 1990, whereas patient number 11 got the disease in 1988. The black dot is the time of enrollment. So patient number 1 until number 5 enrolled into this study in 1980, whereas patient number 6 to number 12 enrolled in this study in 1981. So how do we calculate person year? Let's take the example of patient number 2. The person year is from the enrollment, that is 1980, until the death on 1990, which is 10 years. So the time at risk is 10. So we have to calculate individually for all patients, and the sum of the time at risk is, in this example, is 100, is the person years. So now let's calculate the incidence density. So incidence density is equal to the number of person who get the disease over person years. So ID is equal to 3, because there are 3 patients who get the disease throughout the follow-up, over 100, because we have just calculated the total, which is 100 person years. This slide shows the main difference between cumulative incidence and incidence density is on the denominator. Cumulative incidence involves population at risk at the beginning of the interval, whereas incidence density involves denominator of population at risk throughout the interval. By now, we understand that cumulative incidence measures absolute risk or probability of disease. Example, cases over 10,000 people, which is equal to 5%. Cumulative incidence can be used to construct relative risk. And cumulative incidence consider the variable time period during which individuals are at disease-free and thus at risk of developing the disease. Incidence rate can be calculated with population estimates, example, from a census, and disease from a register. Cumulative incidence can only be used with cohort studies where study participants are enrolled at about the same time. When we look at incidence density is not clearly interpreted as a measure of absolute risk. Example, 50 cases per 1,000 person years. Incidence density can be used to construct relative risk, and it needs to consider death, loss to follow-up, and migration, but the data are not usually available in population estimates. Therefore, person time is difficult to be calculated. Incidence density can only be used with cohort studies, either when enrollment is at about the same time or when the enrollment is spread over time. The term attack rate is often used instead of incidence during a disease outbreak in a narrowly defined population over a short period of time. The attack rate can be calculated as the number of people affected divided by the number exposed. For example, in a case of a foodborne disease outbreak, the attack rate can be calculated for each type of food eaten, and then these rates compared to identify the source of the infection. Let's move to prevalence. Prevalence is an estimate of the proportion of individuals in the population with a given event at a particular time. So prevalence is a proportion, not a rate, because prevalence has no time units. The point in time to which it refers must always be specified. Prevalence is measured from cross-sectional surveys. Data on population at risk are not always available, and in many studies, the total population in the study area is used as an approximation. Prevalence is often expressed as cases per 100 in terms of percentage or per 1000 population. P has to be multiplied by the appropriate factor 10, and n is the factor. This slide shows the basic formula for prevalence. So prevalence is equal to cases divided by population at risk. So prevalence of a disease is calculated as follows. P is equal to number of people with the disease or condition at a specified time divided by number of people in the population at risk at the specified time. And we time this with 10 and n as a factor. There are two types of prevalence. The first one is point prevalence, and the second one is period prevalence. So point prevalence is a proportion of individuals in a specified population at risk who have the disease of interest at a given point in time. So point prevalence is equal to number of existing cases, old and new, of a disease present in a population at a specified point of time divided by number of persons in the population at a specified point of time. Period prevalence is proportion of individuals in a specified population at risk who have the disease of interest over a specified period of time. Period prevalence is the total number of cases, old and new, occurring at any time during a specified period divided by average population over the period, or midpoint estimate. So whenever the type of prevalence rate is not specified, it is usually point prevalence. So this figure shows the patient and also the status of the disease. So the horizontal line here represent one patient. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 10 patients altogether. And all these alphabets has their own meaning. O is disease onset, R is for recovery, D is for death, and M is for migration. So let's look at patient number 2. At the beginning of the study, this person has a disease onset, and the disease continues for a period of time until a period of recovery. And the dotted line shows that they are disease-free. How about patient number 7? So this patient is disease-free for some period of time until this person migrates somewhere else. After the person migrates, there is no more data captured for this patient. So let's calculate the time prevalence at T1. So how many patients at T1 has the disease? We have one here and another one here. So the total is 2. How many patients are all available during T1? There are 10 of them. So prevalence at time T1 is 2 over 10 equal to 0.2 and is equal to 20%. How about prevalence at time T2? At T2, there are 3 persons with the disease. 1, 2, 3. And how many patients are there altogether? We have 1, 2, 3, 4, 5, 6, 7, and 8. The other 2 persons are lost to follow up. So the prevalence at time T2 is 3 over 8 is equal to 0.38, and when convert to percentage is 38%. So this slide shows another example on how to calculate point prevalence, cumulative incidence, incidence density, and case fatality. So prevalence at year 4 here is 2 people with the disease, which is the black line, over 6 people in the population observed at that time, which is all these people. 1, 2, 3, 4, 5, 6. We are not counting individual number 5 because this is lost to follow up. So 2 over 6 is when we convert it into 100%, so it's 33 cases per 100% or equal to 33%. Cumulative incidence of the disease during 7-year period is 3 new cases, 1, 2, 3, divided by 7 same population free of disease at the beginning of the period, which is 1, 2, 3, 4, 5, 6, 7 at the beginning of the period. So 3 divided by 7 is 43%, or we can write it as 43 cases per 100%. Incidence density of disease during the 7-year period is 3 cases over 33 person years. So we have learned how to calculate person years. So when we total up this, we will get 33 person years. So 3 divided by 33 person years is equal to 9.1 cases per 100 person years. And case fatality is, there is only one death here. It means that one death out of 3 diagnosed cases is equal to 33.3%. What is the use of prevalence? Prevalence may express the burden of some attribute in a population. Prevalence is important in determining workload for chronic diseases, and it is useful in planning of facilities and manpower needs. Prevalence is useful in tracking in disease pattern over time, and it is also useful for monitoring control program for chronic condition. So this slide and the following few slides will be showing how the prevalence increases or decreases. So we already know that prevalence is the frequency of an existing event. So you can imagine prevalence as a small balls in a big vase. So when the incidence increases into the big vase, the prevalence increases. But at the same time, there is also people who die of the disease or people who get recovered from the disease. So the prevalence will decrease when there is an increase in death and cures. Emigration will also affect the prevalence. So incidence is not just an increase or frequent nature of a disease, but it is also whenever a new screening test is available, we can see an increase in the incidence. And immigration of people with the disease will also increase the incidence. When there is no recovery or death due to the disease and the incidence it kept increasing, the prevalence will be increased from the baseline prevalence. Meanwhile, whenever there is no new incidence and there is death or cures due to the disease, the prevalence will decrease from the baseline prevalence. So this table summarizes the factors influencing prevalence. Prevalence will be increased if the longer the duration of the disease, prolongation of life without cure, increase in incidence, in migration of susceptible people or cases, out migration of healthy people, which is our denominator, and improve diagnostic facilities and better reporting or notification of cases. Prevalence will be decreased if there is a shorter duration of the disease, high case fatality from disease, there is a decrease in incidence, in migration of healthy people, where our denominator increases, out migration of cases, and improve cure rate of cases. In short, we can say that there is a relationship between prevalence and incidence. Incidence is a measure of risk, while prevalence is not a measure of risk because the numerator has mix of new and old cases and the denominator includes the entire population. However, prevalence is dependent on both incidence and disease duration in stable condition, provided that the prevalence is low and does not vary significantly with time. So we can calculate prevalence from incidence by using this formula. Prevalence is equal to incidence times average duration of disease. This table shows the differences between incidence and prevalence. The differences between incidence and prevalence depends on the numerator, the focus, and the uses. In terms of numerator, for incidence, the numerator is the number of new cases of disease during a specified period of time, whereas for prevalence, the numerator is the number of existing cases of disease at a given point of time. Both incidence and prevalence use a similar denominator, which is population at risk. The focus for incidence is whether the event is a new case and the time of onset of the disease. Meanwhile, the focus for prevalence is the presence or absence of a disease, and the time period is arbitrary, rather a snapshot in time. Incidence is used to express the risk of becoming ill. The main measure of acute diseases or conditions, but also used for chronic diseases. Incidence is more useful for studies of causation. Prevalence is used to estimate the probability of the population being ill at the period of time being studied. It is also useful in the study of the burden of chronic diseases and implication for health services. We have now completed the section on morbidity measure. Mortality measure is an index of severity of a disease. Epidemiologists rely heavily on death statistics for assessing the burden of a disease. Mortality indices can be calculated for the whole population as crude measures or separately for certain subgroups of the population as stratum-specific measures. The importance of measures of mortality are: it's an index of the severity of a problem. It's also an index of the risk of disease. Mortality measure is a good reflection of incidence rate under two conditions, that is, high case fatality rate and short duration of illness. Mortality measure is less expensive method of surveillance, and it provides information on changing healthcare needs. And finally, mortality measure provide clues for the changes in patterns of disease occurrence. There are several problems in mortality data. The first one is incompleteness of records. Second, underreporting of data. Third, inaccuracy in the diagnosis of underlying cause of death due to inaccurate diagnosis by doctors, lack of diagnostic support, and patients suffer from more than one disease. There are also inaccuracy due to differences in classification of disease and missing or wrong information in death certificate. To avoid problems and to ensure high quality of mortality data, a prompt registration is needed. Therefore, ICD-11 codes are used to record data so that they are 90% more complete. So what is ICD-11? ICD-11 is the International Statistical Classification of Disease and Related Health Problems, which provides guidelines on classifying deaths and coding causes of death. The procedures are revised periodically by WHO to account for new diseases and change in case definitions, and now in its 11th revision, so it is called ICD-11. Let's move to the first mortality measure, which is proportionate mortality, or in short, we call it as PMR. PMR is equal to number of deaths from a given cause in a specified period of time divided by total deaths in the same time period per 100 population. Its relative importance or specific cause of death to all deaths in a population group. It also shows the proportion of deaths attributable to a given disease. It is not a rate. It does not convey risk of death but major cause of death. So the highest PMR will show the highest disease with risk of death. PMR is affected by the total number of deaths from all causes in certain age group or population. It is useful in public health because PMR permits estimation of the proportion of lives to be saved by eradication or reduction of a given cause of death. This is an example of PMR for Malaysia. So this data is taken from WHO in 2016. So we can see that PMR is 35% for cardiovascular disease, 16% for cancer, 70% for communicable, maternal, perinatal, and nutritional condition, 4% for chronic respiratory disease, 3% for diabetes, 9% for injuries, and another 16% for other NCDs. In short, NCDs are estimated to account for 70% of all deaths, meaning to say that NCDs are the highest cause of death in Malaysia. Another measure of mortality is case fatality. CFR is equal to number of deaths from a given cause in a specified period of time divided by total cases of same cause in the same time period. So, case fatality measures severity of a disease, and it is used to monitor benefit of certain therapy or intervention in a disease. Crude and specific mortality rate is an important measure of mortality. Crude mortality rate is number of deaths during a specific period divided by number of persons at risk of dying during the same period. When we look at specific mortality rate, we can go to age or sex-specific mortality rate, or we can combine age and sex-specific mortality rate. So this is equal to total number of deaths occurring in a specific age and sex group of a population in a defined area during a specified period divided by estimated total population of the same age and sex group of the population in the same area during the same period. It is important for us to define what are the stages, especially during the early stage of life. What is fetal and who is infant? Who is postnatal, neonatal, perinatal, and so on. As an example, any death before birth during gestational weeks, we call it as fetal death, and any death after the birth of a baby until up to 1 year is infant death. We also have early fetal death, which occurs less than 20 weeks gestational weeks, intermediate fetal death 20 to 28 gestational weeks, and late fetal death 28 up to before birth. Neonatal death is any death after the birth but less than 28 days after birth. And post-neonatal death is 28 days after birth up to 1 year. We also have perinatal period 1 and period 2, which you can refer in this figure. This table summarizes the frequently used measures of mortality. So in this table, the name of the measure, the numerator, the denominator, and also the unit is given. As an example, infant mortality rate is number of deaths among children less than 1 year old of age during a given time interval divided by number of live births during the same time interval. For neonatal mortality rate is number of deaths among children less than 28 days of age during a given time interval divided by number of live births during the same time interval. So we can conclude that rate whose denominators are total population are crude birth rate, crude death rate, and cause-specific death rate. We must also aware the differences with other mortality terms. Example, proportionate mortality rate and case fatality rate. In case fatality rate, the denominator is not the total population. These are the rates whose denominators are live birth. So what is actually live birth? Live birth is a complete expulsion or extraction from its mother of a product of conception, irrespective of the duration of the pregnancy, which shows any other evidence of life. So the mortality measures which uses live births as denominators are neonatal mortality rate, infant mortality rate, fetal death ratio, and maternal mortality rate. The rationale of using neonatal mortality rate is neonatal deaths account for a large proportion of child deaths, and mortality during neonatal period is considered a useful indicator of both maternal and newborn health and care. In particular, maternal prenatal behavior such as nutritional, smoking, alcohol, and drugs, whereas the postnatal mortality rates reflects the quality of the home environment. So the definition of neonatal mortality rate is number of deaths during the first 28 completed days of life per 1,000 live births in a given year or period. So the first 28 completed days means early neonatal death occurring during the first 7 days of life and late neonatal deaths occurring after the 7th day but before the 28th completed days of life. Infant mortality rate is a leading indicator of the level of child health and overall development in countries. They are also SDG indicators, Sustainable Development Goals indicators, together with under 5 mortality rate. Infant mortality rate reflects the mother's health practices, nutrition, use of alcohol, tobacco and drugs, environmental factors, and quality of health services. So the definition of infant mortality rate is the probability of a child born in a specific year or period dying before reaching the age of 1. Infant mortality rate and under 5 mortality rate are not rates. That is, the number of deaths divided by number of population at risk during a certain period of time, but a probability of death derived from a life table and expressed as rate per 1000 live birth. Thus, currently expresses as probability of dying per 1000 under 1 year. If you look at Sustainable Development Goals, goal number 3, which is ensure healthy lives and promote well-being for all at all ages, the goal is by 2030, they want to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. And also, they want to end preventable deaths of newborns and children under 5 years of age, with all countries aiming to reduce neonatal mortality to at least as low as 12 per 1,000 live births, and under 5 mortality to at least as low as 25 per 1,000 live births. The rationale of calculating maternal mortality ratio or rate is complications during pregnancy and childbirth are leading causes of death and disability among women of reproductive age in developing countries. Thus, maternal mortality ratio or rate (MMR) represents the risk associated with each pregnancy, the obstetric risk, nutritional support, obstetric care, anti and interpartum, and level of socio-economic of a country. It is also an SDG indicator for monitoring improving maternal health. There have been dramatic decrease in maternal mortality in many parts of the world, including Malaysia. Maternal mortality ratio is defined by number of maternal deaths per 100,000 live births during a specific time period, usually 1 year. Technically, the denominator of the equation is based on the number of pregnancy rather than live births, but for simplicity, the number of live births is used to estimate the number of pregnancies. Current term is maternal mortality ratio, MMR. The constant multiplier used is usually 100,000 because many countries has MMR which is declined to less than 1 per 10,000 live births. Maternal death is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and size of the pregnancy, from any cause related to or aggravated by pregnancy or its management. but not from accidental or incidental causes. Perinatal mortality rate uses the denominator of live births and fetal deaths. Improvement in postnatal care increase the survival of sick fetus and fall under infant mortality rate. Thus, the number of infants increases. Perinatal mortality rate is needed to reflect pre and perinatal care. And the advantages of perinatal mortality rate is it facilitates comparison for different areas because it eliminates the need to distinguish between fetal death and a live birth. It also fosters collaboration between obstetrician and pediatrician. So now that we have learned about various mortality measures, the question is, how does Malaysian health indices look like? Where are we today? Before we answer the question, we must understand what is vital statistics. Vital statistics are statistics concerning the vital events in human life, such as birth, death, marriages, divorces, and migration. The most common way of collecting information on this event is through civil registration, an administrative system used by governments to record vital events which occur in their population. Civil registration collects this information on a continuous basis and is the only source that provides individuals with a legal document. The Vital Statistic Malaysia 2019 presents final statistics on birth and death for 2018. The demographic indicators such as birth, death, and fertility rates are included in this report. Information on population, fertility, and mortality are useful for policy planning in the areas of health, education, and human resource development in Malaysia. For more information on Vital Statistic Malaysia 2019, you can visit www.statistics.gov.my, where is the host for Department of Statistics Malaysia. As a summary, measures of disease morbidity include incidence and prevalence rate. The incidence rate focuses on new cases and prevalence on all cases. In a stable population, prevalence rate is equal to the incidence rate multiplied by the duration of the disease. And adjusted death rate is better than crude rate for comparison. With that, thank you. See you in the next lecture.